is now 3 o'clock, and it's those of you who don't know me, I'm Ravi Mahajan. I'm the director for the critical care integration and transformation. And Apollo Knowledge Series is part of initiative started by Apollo Center of Excellence in Critical Care. This is, and we've been running this for the last few weeks, and it's a real pleasure to see a great number of participants who join in this interactive and also multidisciplinary initiative. So we always have a medic or a speaker from medical background and a speaker from nursing background. And we choose the topics which are of wider interest, not just for the critical care specialists, but also for people outside the specialty of critical care. As for example, you would have a critically ill patient no matter what specialty you belong to every now and then. And it is therefore good for all of us to keep ourselves updated on how do we initially stabilize somebody who's gone critically ill. So that is the topic for the day. And I'm really pleased and very fortunate to have two excellent speakers for this webinar. And they are Dr. Ebenezer. He's from Chennai, from Vanagram Hospital in Chennai, and Ms. Mamata Devi, who's from Delhi. So that's the other nature of this Apollo Knowledge Series program, that we tend to have pan-India presentation and pan-India representation, and the participants, where they come from, will testify that. So thank you all for being here, and my pleasure now to invite our first speaker, as listed in your invitation, Dr. Ebenezer, to talk about the stabilizing the critically ill from medical point of view. Dr. Ebenezer, welcome.
Thank you, sir. Thank you. Thank you. Good afternoon to all of you. And I'm extremely happy to be a part of this knowledge series. And I thank Professor Dr. Ravi Mahajan for giving me this opportunity to talk on a very, very, very important topic. I do believe this is one thing which, as any member of an ICU team or an ER team, has to be well versed, because the bread and butter is managing critically ill patients. And as all of you know, it is very, very important how we manage these patients when the patients come into the ICU. Either they come from the wards or they come from the emergency in a very sick fashion, or they come into the ER from the community extremely sick. So for every doc, every nurse, and every treating family, this is very, very crucial how you manage these patients. So now I think we will start the session. And as all of you know, I think all of you would be aware about the ABCD approach to acutely ill patients. So that is the approach which we will be doing, we will be following in this particular presentation. And I will try to make it very, very simple so that you can all understand it. So the learning outcomes of this particular topic would be, we are trying to elaborate the clinical assessment of each step of the ABCD approach. How we go about, how we assess a patient when a patient is coming into the ICU very, very sick. And at the same time, we stress on the best methods of oxygen and fluid delivery to acutely ill patients. One second. Sorry, extremely sorry. So we stress on the basic methods of oxygen and fluid delivery to acutely ill patients. And we understand the importance of the SBR approach. We have a sick patient, we are managing that patient, we are stabilizing. Side by side, we should be thinking what next, whether we have the facilities to manage in our setup. I do believe this is being telecast across many of the ICUs in Apollo, and many people are being a part of this series. Some of your centers might have a tertiary care center, and some it might be reach hospitals. So wherever you are, this will also be very crucial. You have a patient who is extremely sick, you stabilize the patient, and then at the same time, you must be thinking what next. And during this process, it's going to be a continuous process of knowledge gaining and continuous process of technical knowledge assessment, and we try to improve on our skills. So self-evaluation and expediting the pathways for improvement is also very crucial. So these are the 5 major steps which you should remember. One is the airway, breathing, circulation, disability, and exposure. So when you think about the airway, when you think about this particular flow chart, this gives you a idea about how you should proceed. So when you see a patient who's acutely ill, and either in the ward or the patient is coming into the ER, and you are the doctor who's on the bedside or the nurse at the bedside, you have to follow this particular algorithm. You have to follow the ABCD approach. So you have to assess whether the airway is patent. So everyone will not have the same expertise and skills. So some of us might be very good at airway management. Some of us may not be very good. So if you need help, always remember, call for help immediately. And if you find that the airway is unsafe, you have to do the particular maneuvers so that you'll be able to secure the airway. We'll come to that later on. And then you assess the breathing. You have to decide how much amount of, whether the patient is requiring oxygen or whether any forms of assisted ventilatory support is needed. And then you come to the circulation part. So you have to assess, you have to give a fluid challenge if the patient is coming in with severely hypotensive, and probably the patient has been just now shifted from the theater, and this particular patient has had a major laparotomy surgery, and he has wheeled into the ICU, and then you notice severe hypotension. You have to fluid challenge him. You have to give him sufficient amount of fluids, or into the ER. A trauma patient might be coming with some major intra-abdominal injury. There might be severe hemodynamic instability or a femoral fracture with huge exsanguination. So those are the places where probably you have to take care of the circulation very, very fast. And apart from that, you will then go on to the disability. You have to look at the neurological status. You have to secure the airway comfortably, and then you have to completely expose the patient and see whether you have missed something. That's very, very important. So many trauma patients, we have missed something in the retroperitoneal area. We have missed something in the back. The back is the area which usually you do not go and assess. So these are things which you should remember. And side by side, there is a very, very important aspect called as history taking. We'll discuss this step by step. Always, history taking is extremely crucial. The initial few minutes as you are doing all the step, to the attender or to the patient, you can always ask about history. Pertinent questions has to be directed so that you will know exactly what kind of disease the patient is suffering and what next to go about. So this particular slide is very important. This will set the ball rolling for this discussion. And then once you start, we'll go step by step. So whenever you see a patient, try to give a handshake. All patients may not come crashing into the ICU, am I right? All patients may not be sick coming into the ER. They might be just in an impending shock. And patients who are in impending shock, when they come in, usually they are quite conscious. At the same time, they might respond to simple questions. So offer a handshake, make them comfortable, and try to go about your initial assessment. And you ask a focused history, you investigate whatever is needed, and do a thorough examination. So here also you have to follow the ABCD approach. For example, if an obstructed airway is there, when you see a patient, for example, if he has had a head injury and he comes into the ER or into the ICU with a tongue fall, so you have to, and there is a gurgling sound, you have to see to that the obstructed airway is attended first. So even though there is a step ladder assessment where you're following a particular path, you always have to be open. You have to always react to situations and see to that correct things are done immediately. So airway assessment is a very, very, very important aspect. Complete airway obstruction is very, very rare. Usually if there is a complete airway obstruction, patient dies within minutes. But partial airway obstruction is quite common, and we encounter that very, very, very common in our ICU practice. So the patients may give you some time before they completely become apneic. So these patients you have to recognize and you have to look into it. What is the reason? What is the cause for the obstruction? Is it so the patient might be having a cerebrovascular incident? There might be a stroke, and because of that, the patient may not be breathing properly. So in those patients, if the patient is completely comatose and if the patient is breathing You might just have to put in an nasopharyngeal airway and maintain the airway. So all these things you have to look into it. And some patients might have an increased work of breathing. They may be coming in, as you know, with severe pneumonia. They may be coming in with a severe breathing difficulty. So a lot of things are there. The commonest things of partially obstructed airway is a reduced level of consciousness. This could be multifactorial. Even there are instances, I'll just give you a very, very simple example. A patient coming out of the theater, he has been just now reversed and he's just out of theater. Probably he's still partially reversed and he's still not come on to the relaxants completely. And there is heavy sedation has been given. He's not completely out. There could be some element of hypoventilation. Apart from that, because of the sedation, there could be some element of tongue fallback. All you need is a simple maneuver. Try to maintain the airway. Another 15 to 20 minutes, he'll be normal. So these are things which always you should look. You have to look at the situation and see to that. And there are some maneuvers which you can always do: a chin lift maneuver, a jaw thrust maneuver. These are maneuvers which I have clearly told you here. These are things which you can use to maintain the airway. And apart from that, there are some airway adjuncts like an oropharyngeal or a nasopharyngeal device which can also be used. So another important aspect is normal saturation does not exclude obstruction. You have a patient who's coming in and who is having gurgling sound, who's not able to breathe well. You think that there's a partial obstruction. You connect the pulse oximeter and you're looking at the saturation, it is 98. That should not give you a false picture that the patient is doing well. So remember, normal SpO2 does not exclude obstruction. Suppose if there is an obstruction and if you want to maintain the airway and you call for help and still experienced people are coming into the spot, you can always perform the triple maneuver and you can try to maintain the airway perfectly. Apart from that, sometimes there might be head injuries or spine injuries which you're suspecting. Then you have to be careful and you have to see to that a modified jaw thrust is used. And sometimes you might have to be some more careful. You may have to use a inline stabilization method. So if all these maneuvers fail, then always you can insert a oropharyngeal airway and try to maintain the airway. This is also very important. So once you have reasonably maintained the airway, the next thing would be you're assessing your breathing. You're assessing the breathing, how the patient is breathing. Is the patient breathing with a very, very fast respiratory rate? Very tachypneic patients are usually encountered when the patient might be having sepsis or when the patient is having a severe COVID pneumonia, which is happening in many parts of the world. They might be tachypneic coming into your ICU. They might be hypoxic also. So all the patient might be having a simple pyrexia. The patient might be having high fever. High fever in turn results in tachypnea because the patient is breathing at a very fast rate. So many things, from mundane things like fever to very, very dangerous things like COVID pneumonia can result in tachypnea. So you have to understand what kind of patient you're dealing with. So sometimes you have to be very careful in how you elicit the signs and symptoms. So this can lead to respiratory distress. When you speak to the patient, you will find that their inability to complete sentences and their accessory muscles of breathing, accessory muscles of respiration are working overtime. Sweating is there, and some of them might be cyanosed, and some of them might be turning blue. So these are things you should look for. And a focused clinical examination is very, very important. As usual, nowadays, very rarely we're using the stethoscope. I think there is a role in certain conditions. So that tracheal palpation, percussion, auscultation, all of this will uncover the diagnosis. So you might have a tracheal deviation due to a tension pneumothorax. We have seen patients with COVID pneumonia who had been discharged home, who went home, and then they come back to the ER with severe respiratory distress. And you take an X-ray, there's a huge pneumothorax sitting there. Okay. So these are things which are very, very important because you can, even with your clinical examination, even before you do an X-ray and you get the diagnosis, you will be able to find out. That a heightened sense of suspicion can be elicited by having a detailed examination. And sometimes the patient can have a severe cardiac failure, and this might also result in an increased incidence of tachypnea. High respiratory rate can be seen. So once you assess these patients, you have to supplement them with oxygen. That is also very crucial. So we try to maintain a saturation of around 94% or above, and the appropriate oxygen delivery devices can vary. The patient might be very, very comfortable even with a small nasal cannula. With even 2 to 3 liters of oxygen, he might become comfortable. Or it might even go up to a position where he needs a bag mask ventilation. So you have to assess the patient. At the same time, you have to target an oxygen saturation of 94% and above. So these are methods by which, suppose the patient is very, very uh, slightly comatose, patient is not able to breathe well, saturation is not maintained, you can always start off with a self-inflating bag and you can start giving him high oxygen supports. So once you do this, that there are some patients who might need intubation. For example, everyone need not, everyone who is having a desaturation, hypoxemia, or who's having a drop in GCS, not all of them land up in intubation. There are some patients, even after initial maneuver, etc., if they are not doing well, and if they continue to be hypoxic, or if they're not able to maintain a decent patent airway, it's very, very important. You may have to intubate them. But indications for intubations are not only due to that, they can also have other constellation of symptoms. Suppose the patient is extremely hemodynamically unstable and you feel that he might crash at any moment. So those are some conditions where you may have to intubate the patient, even if the airway is okay, even if the breathing is okay, but the patient, you are anticipating an impending cardiac arrest, or if you're anticipating the patient is going to have an impending shock, and if you're feeling that the patient is going in for severe hemodynamic instability, you may have to intubate the patient. Okay. Suppose you have a patient who is having recurrent attacks of VT. In between, he wakes up completely. He's completely normal. He's completely waking up. His oxygenation is not a problem, but he keeps on going in for a recurrent VT attacks. So you try to, whatever you're able to do, you're not able to clearly solve the problem. So at that time, if you feel that the patient is fitting into a category where there could be an underlying coronary artery disease, and if you feel that the patient might be having, if the patient is having angina, etc., you may feel that the patient needs to go to the cath lab immediately, and you may have to protect him. So at that time, you may intubate. So there are so many reasons. So either it could be a hypoxic respiratory failure, or sometimes in some patients, it could be a hypercapnic respiratory failure. In some patients, it could be a mechanical respiratory failure, whereby your muscles of your chest muscles, etc., they are not functioning well. Your pump, that is the respiratory pump, is not working adequately well. So in those conditions also, you may have to intubate. So these are the various conditions which I have enlisted now. I'll just tell a few conditions. So suppose you are thinking in terms of a position where the patient is not able to maintain airway and bag mask ventilation is becoming very difficult, and you're suspecting aspiration from gastric contents, and you need to, and there is a drop in level of consciousness, and patients is becoming very comatose. There are a lot of indications where you may have to put in the tube. So just a few points about the various laryngoscopes, etc. I think all of you will be knowing this. So this is the apparatus which we use to secure the airway. So we have a laryngoscope. There are 3 types of blades: McIntosh, Miller, and Wisconsin. And we have an endotracheal tube, and in some places they use a stillet to intubate. And it depends upon the operator's efficiency as well as the technical warehouse, and it varies from place to place. Sometimes most of the patients whom you're going to intubate in the ICU, in the sense an early stabilization of critically ill, most of them will have a full stomach. So remember that. So you may have to follow the rapid sequence induction, and you may have to intubate them as quickly as possible. And you may have to do the Selix maneuver. And this is a representation of how, for a beginner, when he looks into the oral cavity, and when he puts in the scope and when he lifts it, this is how he sees the vocal cords. This is how he'll see the epiglottis and the arytenoids. And through that space, you're going to insert the endotracheal tube. And here you see a trauma patient where there is a doubtful C-spine injury. So this is how it has to be intubated. 2 operators have to be there. The other person has to see to that the manual inline stabilization is done effectively, so that you should not compound the problem. Okay, that's very, very important. Whatever we do, it should be for the betterment of the patient. In some situations, you might be faced with a situation where you're not able to intubate the patient. and call for help is not coming immediately, or even sometimes intubation might be difficult even for the most experienced anesthetist. You might have an issue. So at those times, you can slip in an LMA and you can buy some time till some help comes. And this is how you have to put in an LMA, and you can start ventilating the patients. This particular device has been very, very useful in life-saving situations. Definitely, there is a possibility of aspiration of gastric contents, but we can go into that later on, because at the moment, saving life is very, very important. Somehow we have to ventilate and somehow we have to oxygenate the patient. So if you're not able to intubate, you have these gadgets which you can use it. So once you're done with your airway, breathing, etc., you're looking at the circulation also. So for example, there are various things which you should, the patient might be coming in with a severe tachycardia, and that might be a thready pulse. The patient might be completely confused. He might be agitated. In shock, cerebral hypoperfusion will be there. He might be completely obtunded also sometimes, or he might be irritated. Sometimes ARDS patients are extremely irritable. You can sense it the way they are. So these are things which you should look into it. And apart from that, you have to see to that the circulation is achieved as early as possible. So that is also very, very crucial. So I have just put in the Poisson's law. Here you can look at the flow is directly proportional to the radius, and it is inversely proportional to the length of the tubing. So when you're going to resuscitate a patient in shock, see to that 2 16-gauge lines are provided, so that the length of the cannula should not be very, very long. At the same time, the radius should be reasonably big, so that you will be able to provide the largest amount of bolus of fluids as early as possible. I again repeat, there is no need to go for a central line when you resuscitate these patients. Okay. And when you think in terms of shock, I think all of you know what do you mean by the term shock is a circulatory insufficiency that creates an imbalance between oxygen supply and demand. So there are a lot of surrogate markers. You look at the lactates, etc., and there are so many things which will give you an idea whether a patient is in shock. But simple things first, at the bedside, you will be looking at certain things. So we'll come to that later. But primarily, when you think in terms of shock, it is either going to be a hypovolemic shock, a cardiogenic shock, or a distributive shock, or an obstructive shock. So hypovolemic shock, for all of you, for beginners, common examples are road traffic accident causing long bone injuries and femoral shaft fractures. There'll be huge exsanguination, even up to 1.5 to 2 liters. If the pelvic bones are involved, usually there is a huge drop in hemoglobin. Those patients will be coming in with severe hypotension. And if you're able to resuscitate them extremely well, you are going to save the patient. Okay, the orthopedician is going to come and fix the problem, but once the way you resuscitate, how you resuscitate, that is very, very crucial in this golden hour. So it could be due to hemorrhage, or sometimes that could be due to an inadequate circulating volume. For example, in certain countries and tropical countries, there could be acute diarrheal disorders like cholera, in which patients lose a lot of volume. So those patients will come to you severely dehydrated, and in those patients, you might have to pick up the circulating volume as early as possible. And sometimes there could be a fluid loss due to burns. The patient, usually even with 90% burns, if you see them, they will look sitting, they can even walk and come into their ICU. That's how they usually come. But after that, you will see how much they deteriorate. So the replacement of the fluid and circulating volume is extremely crucial. Cardiogenic shock is primarily caused by pump failure. It could be a straight coronary artery disease, a left main block, resulting in absolute pump failure. So at those particular patients, you might have to start the protocol, and you might have to take them to the cath as early as possible. Sometimes they might have with a systolic dysfunction, and even an arrhythmia might be there. So you have to assess the problem and see to that you treat them appropriately. And distributive shock caused by maldistribution of blood flow from peripheral vasodilatation and decrease in SVR, commonly in sepsis. So sepsis is a condition in which there is peripheral vasodilatation. So septic patients, when they come into the ICU, when they come into the ER, already they are peripherally extremely vasodilated, and they might be having high fever also. And last 3-4 days, they might not be having any amount of fluid intake also. So these patients, however much it's important, you have to resuscitate them with good amounts of fluid so that their peripherally vasodilated compartments get filled up so that you're able to maintain a certain element of SVR with the help of vasoconstrictors. Coming to obstructive shock, cardiac tamponade, tension pneumothorax, pulmonary embolus, all of this can produce obstructive shock where you have to release it as early as possible. If it's a cardiac tamponade, go ahead, do a pericardiocentesis. Tension pneumothorax, put in an intercostal needle, later on go for an ICD. And if it's a pulmonary embolus, definitely, if that's causing RARV dysfunction, hemodynamic instability, you have to thrombolize the patient as early as possible. So this is the tabular column, which clearly tells you how you're going to assess a patient with shock. The patient might be tachycardic, blood pressure might be low. I again want to emphasize here, BP alone is not an indicator for shock. Some patients, even they might be in shock, they might be having a normal BP. Okay, so these things you must remember. You have to look at the mental status, etc. And when you resuscitate, you can choose either colloids or crystalloids. Crystalloids are as good as colloids. You need not always run for a gelfusion or a hydroxyethyl starch. Please resuscitate with balanced salt solutions as early as possible. Whatever is available with you, try to resuscitate and resuscitate effectively. These are the vasopressors and inotropes which we usually use. And when it comes to septic shock, usually the combination of norepinephrine is the drug of choice. And when you have a patient probably with a cardiac LV, poor LV with the septic shock, probably those patients, a dobutamine and norepinephrine might be useful. Dobutamine will take care of the cardiac pumping activity. Remember, dobutamine can also cause some element of vasodilatation that will be taken care by the norepinephrine. You can even use adrenaline in some patients. Okay. So disability assessment is the next step. Here you have to look at whether the patient is alert, voice, pain, and unresponsiveness. You have to go through this fast and completely expose the patient. Try to see to that you don't miss anything. Please avoid hypothermia. Hypothermia should be addressed at the point of entry itself. Okay. And try to look for missed injuries. Once you've done all this, now you know. For example, there is a patient who's having a severe intra-abdominal injury, and you've done a fast and you've seen a collection there. Patient is hypotensive, you're resuscitating, you've done everything, and patient is having severe hemodynamic instability, you even intubated the patient, but you are in a setup where you don't have a surgeon immediately, or you don't have a surgical gastro immediately available to take the patient. Always think on the back of mind, you have to transfer to a center, and the transfer has to be done very, very prudently and very safely. Okay. Or if you feel that the patient has to go to the theater immediately, as you're resuscitating, inform the surgical team, inform the anesthetic team, let them be there, let them come as early as possible to the hospital so that all of this can be done and immediately the patient can be wheeled into the theater and the surgery can be done. SBAR approach has to be followed. So diagnostic synthesis, investigation, and definitive management is also very important. As you resuscitate, remember, resuscitation is not the only goal. You have to keep looking. You have to have a working diagnosis with you. So once you have the working diagnosis, you'll be able to factor in other things and you'll be able to keep the things. You'll be always ahead. You have to be 2 steps ahead. That's very, very important. That's where you can save the patient. So just giving fluids, just giving vasoconstrictors, trying to maintain, just resuscitating, that alone is not enough. You have to have a working diagnosis. You have to rule out all the things one by one, all the H's, all the T's, etc., and try to see to that the patient is saved. Okay. So very rarely, sometimes you might have a critically ill patient who comes in and who collapses before you, or in the ward, you are called to suddenly evaluate a critically ill patient. Actually, I'm just putting these slides so that you should know that apart from that, sometimes you may have to identify the rhythms also. For example, a ventricular tachycardia, a ventricular fibrillation. You might be just called into and see you, there'll be complete asystole. You might have to start your med call. You might have to start resuscitating the patient. You have to go through, you have to follow the protocol, you have to follow the algorithm, and you have to resuscitate these patients. And the take-home message, finally, what I would like to tell is, remember, ABCD approach is a cornerstone of stabilizing critically ill patient. So at the ER or at the ICU, when a patient is critically ill, the early period, the period when you see the patient, extremely crucial. How well you address the problem at that juncture is very, very important. A haphazard manner of addressing the problem will not give you the results. So you have to follow the approach. You have to see to that how you follow that approach. That is also very, very crucial. Patent airway is extremely crucial. Sometimes people miss it. And because of that, we have lost patients who might have been saved. Remember, crystalloids are as efficacious as colloids for resuscitation. You may not get blood, it may not be available, you may not get colloids in some centers, still no problem. You just continue to resuscitate with crystalloids. Norepinephrine remains the first choice of vasopressors. If you're still not able to fix whether it's a cardiac, septic, etc., it's always safe. You can always start norepinephrine. And as the diagnosis unfolds, you can always see to that you are able to correct your treatment pathway. But remember, nothing can supplement a quick, focused history and examination. Always remember, you might have every gadget in the world. You might have an ultrasound at your disposal. I still remember when I was a consultant in one particular hospital, patient was coming out of the theater into the ICU. Patient was hypotensive. They have undergone a debridement of the right lower limb. And immediately the registrar, he just took the ultrasound and he was looking for the IVC. He was looking for everything. I just went, I just removed the cloth and I looked at the leg. The leg was completely soaked with blood. Okay, so that is there, it is hitting at you. They have, it has been, the hemostasis has not been secured and he's leaking blood there. And you take the ultrasound and you do a IVC, etc. So remember, a quick focused history and examination is always important. Along with this, if you're able to effectively use these gadgets, great. And zeroing on a working diagnosis will always clear the path for further care. Remember, once you stabilized, how well you give definitive care, that is very important. So as an intensivist, as an ER person, you have to zero in on a working diagnosis so that you have to clear the path effectively for further care. And SBR approach has to be followed for transferring critically ill. And when you transfer critically ill patients, it is your responsibility. See to that the safety of the patient is maintained in a very, very appropriate manner. Time is life. It's very important how we address time and see to that you do everything in an effective and erudite manner. Thank you. Thank you.
Thank you, Dr. Ebenezer, for a brilliant talk. I must say, I really enjoyed listening to the passion with which you deliver the talk, and the fact that how you brought down the take-home message to be so important. At this stage, can I welcome the participants who have joined us lately? And also, if you could use your chat box for the questions, which we will try and answer at the end of both the talks. Coming back to Dr. Ebenezer's take-home messages and the talk, I really like the facts, Dr. Ebenezer. There were some real golden nuggets in that talk, real good learnings from that talk. When you say, if your SpO2 is normal, that doesn't mean that you haven't got respiratory problem. You're absolutely spot on. When you say if your blood pressure is normal, doesn't mean that your circulation is good. That's also a spot on. And common pitfalls that we clinicians fall into, sometimes just looking at the figures, but ignoring the patient and the patient's condition. I think your take-home message of working diagnosis, being a clinically oriented throughout, whether you are resuscitating somebody or stabilizing somebody, that's not the only goal. The goal is beyond that, and that is to come up with a working diagnosis so that you can treat the patient. And of course, your final line, the time is life. And you talk about golden hour and how important it is if you are in respiratory distress to correct with the maneuvers, the airway, all those points, real good take-home messages. Thank you indeed for such an excellent talk, Dr. Ebenezer. I'm sure there will be points of discussion and questions which we will have in the chat box. So participants, please send us more questions so that we can have a good interaction after we've had the next talk. And that is, so we joined here, welcome, Ms. Mamata Devi. She is from Delhi Apollo Hospital. Ms. Mamata, please.
Thank you, sir. First, let me share my slides. Okay. Namaste, everyone. I am Namota, charge nurse of Pediatric ICU in Indraprastha Apollo Hospital, Delhi. Today, I'm going to talk about early stabilization of critically ill patients in nursing perspective. And I would like to take the opportunity to thank Professor Ravi Mahajan sir for giving opportunity. And I also would like to thank our Captain Usha Banerjee ma'am for providing the opportunity to perform in this platform. And also Madam Gracie Philip, Assistant Director of Nursing, for mentoring and helping in this platform. So let's look into the introduction and what is critical care nursing. So it is the field of nursing with the focus on utmost care of critically ill patient or the family. So we as a nurse is very vital role in critical care nursing, and whatever we provide in critical care nursing is very crucial and mandatory. So let's understand about what is critically ill patient. Critically ill patients are those who are at risk of actual or potential life-threatening health problems. So let's look into the classification of critically ill patients. So critically ill patients are categorized as levels, and there are 0 to 3rd level. So level 1 comes normal and acute ward care patients. In level 1, there are the general patients at ward, but those patients are at risk who are requiring monitoring for deterioration, and also patients who are transferred from the ICU and the step down patient that will be requiring a monitoring. Level 2 will be moderate, highly dependency patient that all are comes in under ICU category. Though, for example, like post-operative patients and the patient who are transferred from ICU, just recovering from the critical stages, and close monitoring and observation is required. So level 3 will be in critical and crucial condition, like in ICU sector, patient who are requiring respiratory support with ventilation, shock patient, and multi-organ failure patients. These are the category of critically ill patients. So what are the conditions considered as critically ill patients? I'll just give you the example. These all are not the only case of critically ill patients. These are some examples that critically ill patients are: acute respiratory failure, acute myocardial infarction, cardiac tamponade, severe shock, heart block, acute renal failure, organ dysfunctions, severe burns. So let's understand the principles that nurses of the critical care nursing. What are the principles that we have to follow while caring the critically ill patient? Appropriate care delivery is very important. Whenever you provide a care, it should be standard, uniform, and we have in the nursing field, we have created so many SOPs to care the patient, and especially for the critical care nursing section also. And next is de-stress and relief. When a patient is admitted and hospitalized in the hospital, and patient attendants are very much anxiety and stress, so you have to take a responsibility in this case, and being a nurse, you have to make sure that patient attendants are counsel and relieve their stress. And also you have to provide compassionate care and support to the patient and attendant. Maintain always dignity, and whenever you provide any care to the patient, always first priority is the information to the patient and attendance is always mandatory. And also rehabilitation for the patient and critically ill patients. You have to initially start right from the admission itself, what all rehabilitation care should be related and what to be provided. So always involve the patient and family when caring the patient, and it should be a patient-centric, because the patient and family are the main important over here. So next, the assessment and clinical examination. Let's understand how to assess the patient and clinical examination as per the nursing perspective. As earlier, the previous speaker has very thoroughly mentioned about the how to assess and examine the patient who arrive in the emergency or in the ICU sector. And then this is the way ABCD approach we have to follow, and this is how we have to assess the patient. So first thing is airway. We have to go in the sequence wise. This is how you will find out the critical issues problem in the patient, and after settling down the step by step, you have to move on to the next step. So I will not go thorough in this, because the previous speaker has very thoroughly explained about this. So you have to first check the airway, breathing, circulation, disability, and exposure. Airway, you will look for any abnormalities, obstruction, or any altered ventilation and lung collapse. You have to check it, and you have to immediately provide the management. So if any airway obstruction is present, then you have to make sure that give the position, that head and neck positioning, head tilt and chin lift method, and the jaw thrust method, as it is already mentioned in the previous speaker. And if any oral secretion is accumulated, you have to suck out the secretion and clear the airway. And if it is needed, you have to place the oral and nasal airway. After settling down the airway, then you have to move on. The next step is breathing. You have to assess the respiratory effort, or what is the rhythm of the respiration, and whether patient is taking so much effort in breathing. And if patient is requiring any oxygen support, by seeing the saturation level, you will find out that patient is requiring oxygen supplement or not. You have to make sure that patients should maintain above 95. If it is less than or equal to 94 and patient still requiring oxygen supplement, and you have to provide the oxygen supplement by providing a nasal prong or nasal masks or any other non-invasive method. And make sure you check the air entry, auscultation, bilateral air, any wheezing sound, crackle, anything, and look for pneumothorax also. And after settling down, you will move on to the circulation. When you talk about the circulation, you have to make sure that your observation and assessment skill is very important. So here you see the C, and this also you have to make the C of how you are assessing the patient for circulation, anything. First, starting with the blood glucose level and capillary leaflet, and then any excess cannula, anything it is available or not, and blood gas level, and monitoring of blood pressure and the temperature, and your assessing of the 12 leads ECG and urine output. These all are the mandatory vital that you need to check and make sure that patient's circulation has been maintained. And these for neurologic disability. And when the patient comes, you have to assess for the level of consciousness. And at this time, and patient is in a critical and emergency situation, you cannot be checking the patient's neurological assessment in thoroughly. So you have to follow the step of ABPU. So first you check the alertness of the patient. If patient is alert, then you don't need to go into the next step. If patient is not alert and not responding, then you have to check for verbal stimulation. If a patient is not responding, then you have to make the painful stimuli and check the response. And if it is not responding and patient is unresponsive. And next step is exposure, and you have to expose the patient and check for any unusual happening on the patient. So now next comes the management of critically ill patient. So as a nursing perspective, the nurses are vital important and taking care of the critically ill patient. First mandatory thing is complete monitoring. So you have to monitor respiratory care, respiratory rate and rhythm, and what is the effort, everything you have to look for. Cardiovascular care, gastrointestinal and nutritional care. If patient is requiring any supplement or any nutritional support, that have to look for. Neuromuscular assessment. Here you can check the neuromuscular assessment GCS in thoroughly and monitor in the chart. So every care and assessment has to be documented in the chart and provide the comfort and reassurance to the patient. So next, and infection control is the most vital, important chapter in the critical care nursing. If you provide the all the care and necessary whatever you are providing, but you don't focus on the infection control, and patient is going to be definitely lose their life. So you have to focus meticulously on the infection control right from the starting, washing your hand, and by following the steps of hand washing technique, which is approved by the WHO, and the 5 moments of hand hygiene you have to follow. When you before touching the patient, you have to wash your hands and use the sanitizer and rub the up. That protocol have to be followed. And provide the personal care to the patient, like skin care. When the patient is lying on the bed, you have to provide bed care and turn the patient around, to avoid developing of back pressure ulcer, and provide oral care to avoid the fungal infection. So fluid and electrolyte balance is very important, and you have to monitor the intake output chart and document. Elimination needs, like if patient is voiding, and you have to clean and monitor the color, quantity, and nature, everything. And communication with the family member is very important. Whatever you do, you always have to update to the patient and attendant, and make sure you inform everything. So infection control is a vital role. Like I mentioned, that here is some step that you have to follow. Washing your hand and avoiding touching is the nowadays as per related to COVID protocol also, or as in the general also, you have to always make sure that you follow the infection prevention control. So in infection control, hand hygiene is mandatory, and wearing of PPE when you are providing any procedure, or you are performing any aseptic procedure to the patient, and these all are mandatory. And environment cleaning, and when a patient is in ICU around, you have to make sure that the surrounding of the patient is clean, and ICU per shift wise cleaning is mandatory to avoid the infection. And handling of linen, when you change the linen, you have to discard in the appropriate bin, and appropriate segregation of linen waste is mandatory. And if the patient is any communicable disease or any immunocompromised patient, and you have to isolate, and you have to maintain the isolation policy or reverse barrier nursing if in case of immunocompromised patient. Fluid and electrolyte maintenance is very important in critical care patient. You have to always monitor the intake output of the patient. and monitoring of sodium pump, that patient's electrolyte balance is important, and to recover the patient fast. So you have to monitor the blood glucose levels. In the critical care sector, patient will be always having the all the lines and tubes, catheter that has to be looked after and care. These are the nurses' integral parts. So nurses are the responsible for this, and the nurses are plays a vital role to prevent and control of infection. So when catheter, urinary catheter has to be clean before and after insertion, and here you have to follow the bundles of protocol, that COTI bundles, what hospital, in Apollo hospital we are following. So when inserting the catheter, you always have to follow the protocol of bundles, washing their hands and wearing gloves, sterile technique inserting. Then after inserting, they have to secure the catheter and clean the catheter in every shift, and make sure the catheter is not kink and loop anywhere, and the free drainage of catheter, and look the color and nature of the urine output. And the arterial line and central line, you have to make sure that dressing has to be transparently paced, and if look for any sign and symptom of any infection developed. And you have to make sure that rub the hub policy before and after using of central lines. And the intercostal drainage care also, you have to make sure that dressing has to be clean and transparent, and you have to look for any abnormal this thing, and make sure that you check the colon movement. And endotracheal tube care, you have to secure the tube so that the tube will not comes off, and you have to secure the tube. And if any secretion or any visible secretion, you have to do the suctioning. And pain is the fifth vital organ, vital sign. So it is the very important role for the nurses, that you have to monitor the pain. So pain assessment, we have followed the protocol of pain assessment in numerical or visual assessment, or behavior rating scale. So any of the pain assessment you can follow. And when you are assessing the pain, you have to make sure that patient is comfortable. And when you assess the pain, patient if patient is conscious, make sure that you ask the patient any difficulty or any pain. So if you're providing the pain management, you first, being a nurse, you have to make sure to keep the patient in comfortable position, and you have to release the anxiety. And if patient is requiring any pain medication, then you can provide oral, intravenous, epidural, or PCA. So communication with the relatives is very mandatory. When you are communicating with the patient, you have to inform timely information before doing any procedure. Patient family is always have to be involved when you are providing any care to the patient. So you being a nurse, it is mandatory that you have to empathize and compassionate with the patient and attendant. So each of bit communication should be documented. When whatever you are providing, performing to the patient, that has to be documented. And always have to ensure that consent has been obtained before doing any procedures. So what all information we need to provide to the patient attendant. Discuss whatever you are providing, goals and cares have to be discussed with the patient and attendant. Written instruction guideline to provide information about the critical care has to be explained. And you have to make sure that patient and attendant knows how to contact the nurse and where to the search information. You need to explain them. And consistency in the nursing care. You have to explain them how to visit the visiting hours policy. You have to explain them. Access to telephone and bathroom food, the surrounding overall orientation has to be explained to the patient attendant. You always have to be provide effective communication to the patient and attendants, and make sure they are aware of the relaxing area surrounding or lobby to the patient attendant, so they will not be lost or difficulty finding the areas because they are new in the hospital. So a proper orientation is important to the patient attendant. Needs of the family and critically ill patients. So personal care about the patient is important. You have to encourage and always make them believe that, and always keep hope that patients are admitting in critical care or critically ill patient. They are always anxious and worried about patient's condition, and they sometimes they lose hope that they will not be seeing the patient no more. So by seeing the condition in the critical care sectors, and they are always lose hope. So you have to encourage them and empathize them, and you have to provide the compassionate care. And waiting, you have to always provide at least critical care patient where the ICU is belong, that you have to provide the nearby waiting lobbies for the patient attendant. When changes in the patient occur, that when the patient condition is deteriorate, then you always have to be informed to the patient attendant and always escalate and aware them that the patient is deteriorating, and they should be available around the ICU. And patient prognosis should be explained, that this should be done by the doctor, but at least being a nurse, your responsibility to make sure that the patient attendants are aware of the prognosis of the patient, whether patient is recovering or deteriorating. This should be informed always. Have question answer honestly. So when patient they are asking any queries, and you have to give the correct information, and you have to be always honest about what you are informing to them, and you cannot be giving the false information, or you are not changing your opinion. No specific about the patient's progress, and be allowed to see the patient and frequently. So this in the ICU sector, we have a visiting hour policy, but make sure you explain them what is the visiting hour policy, so that they come on time and visit the patient. For critically ill patient, patient attendants always they believe in the their releases, that they wanted to provide releases need. So allow them to do some prayers at the bedside, or they're tying some religious things to the patient, or this should be allowed. Thank you so much. This is all that.
Thank you, Ms. Mamata, for such a brilliant talk. Another good talk today. So I really thank both the speakers. I think, Mamata, in your talk, you have brought out such good principles of good nursing care applicable in critical care situations. You talked about levels of care. Of course, the critical care doesn't mean that everybody has all the organ supports. You could be critically ill, but shaking hands, as Dr. Ebenezer mentioned in his talk. So right from level 1A, 2, 3, we have different levels. But in your talk, what I really liked, Mamta, was the fact how you talked about empathy, the compassion, especially for critically ill patient, especially who's just come to the intensive care unit and is being stabilized. And the needs not only of the patient in terms of pain relief, in terms of comfort, in terms of other requirements, but also the needs of the family and how they are very important. So not only this is important for caring or providing the care to the patient and the family, it's also a very important part of our profession as a whole to be compassionate and to be empathic to the needs of the patient and of the family. I will touch on medical legal aspects here as well. I think it is important. If we want the complaints to be kept to minimum, and if we want our hospitals to be known for providing empathic care and our units known to be providing empathic care, and we want to keep the medical legal litigation to the minimum, I think the aspects you both mentioned with regards to the communication, with regards to the documentation, are very, very important. So not only for providing the care, but also for protecting ourselves and our hospitals and units from potential litigation. I think these are very, very important points. Thank you both for such brilliant talks. I'll welcome any comments or any questions for our speakers from the participants. And before they warm up to the discussion, can I ask Dr. Ebenezer or Mamata, please could you share a few more examples of how initial stabilization was crucial in saving life, as for example. Dr. Ebenezer mentioned one example where the colleagues were looking using ultrasound, but then missing out on something very obvious. Those are real good examples, take-home examples for our participants. Any more such examples? Dr. Ebenezer, you first.
Okay. Actually, in day-to-day clinical practice, we come across many such examples, but I'll just speak on certain things which comes to my mind right now. For example, you have a patient who has had a double valve, who has operated, and he goes home. Okay, in India, we put the patients on oral anticoagulants. Okay, the patient went home with an oral anticoagulant, and then after a week or 10 days later, he comes in back to the ER extremely tachypneic and tachycardic also. So once the patient comes in and you start looking at why the patient is tachypneic, tachycardic, mundane things you'll be looking at. But at the same time here, that's what I again tell the history. You have to look into the discharge notes, you have to see for what particular surgery he got admitted. So once you know that there is a double valve has been done, then suddenly he's coming back. Either that could be a heart failure, or maybe then you look at it, there is an oral anticoagulant also going. What type of valve is being put? Many places mechanical valves are there. So when you look at all those things, and back of the mind, you should immediately think probably there is a stuck valve there, or there is a thrombus sitting there. Then you immediately, if you're able to hasten that particular step, and if you're immediately able to take the echo. So this is where the echo plays a major role. See, here is a correct clinical condition where immediately, the moment you put the echo there, you put the probe there, and there you see a thrombus there, or the valve is not moving, you got the answer. So immediately you give a call for the cardiothoracic people and the cardiologist, and they're involved. And if needed, a thrombolysis is done as early as possible, and the patient is saved. So this is an example of how that particular decision-making process at the earlier phase is very important. And you might also, sometimes you might have people coming in with, for example, a couple, they might have gone to a restaurant outside and they might have something to eat there. And probably the lady tried something new there. She tried something, a different type of crustacean dish, a shellfish or a crabfish. She decided to try that. And after that, she started slowly developing rashes, itching, etc. And she had some constricting feeling in the chest, etc. Then she was not feeling well. She comes into your ICU. but she comes into the ER. She's completely dressed for a party. Looks like that. She's looking hale and healthy. The only thing that she's telling is there is some itching and I'm having a mild constricting feeling. And the ER doc and the ICU register, you have to be careful at this particular moment. So a mild constriction can in a few minutes or even a few seconds slowly go for an impending respiratory distress. A stridor could also come, and the patient similarly, as she was talking, she felt the voice was becoming gruff and she was not able to speak well. She was not able to complete sentences. And slowly she started telling it is constricting my throat and you can see edema coming through. These kind of patients, immediately you have to electively intubate them and treat them with anaphylactic drugs. Okay, so this is where you have to be careful. And critically ill patients is a dynamic process. Sometimes even in ICU, patients who are stabilizing, who are on the way to go to the ward, they're ready to go to the ward, etc. Those patients can also become suddenly sick. Okay, so for example, you have a patient who's a dialysis patient, CKD patient, and you saved him, he's been removed off the ventilator, etc. And you decide to ship the patient to the ward, and the line is day 5 old, day 6 old. You decide to change the line, and your registrar has changed the dialysis line. And morning you come for rounds, and the patient is lying. You find him coughing slightly, and at the same time you see the saturation is also around 90. And the staff is telling, sir, till 2 hours back it was 100%, not on any oxygen, etc. Now slowly oxygen requirement is coming, sir. Probably he needs a dialysis. I'm not sure. Probably he needs a dialysis. Then I ask him, anything else? Then she tells, so today morning they placed a dialysis line. Oh, fine. Did you check an X-ray post dialysis? Sir, still not, we have not yet checked. Then you go and you see the X-ray post insertion and you see a pneumothorax there, which is evolving. Okay, so these are things which time is very important. You have to pick them up as early as possible. So these are some things which you should understand. So even in ventilator patients, suddenly you might have a tube block. The earlier you pick up, and even in tracheostomy patients, they might be perfectly in a very room where they might be having very minimal oxygen. Suddenly they arrest because of tube blocks. So when the symptoms of tube block, when they have some difficulty, etc., it's very important you ascertain where the problem is and try to zero in on the problem. So these are something which comes to my mind. And recently also we had a patient who had a PTCA done and who was brought from the cath lab. Okay, and it was a femoral approach. And sister, as usual, after 3-4 hours, she removes the femoral sheath. I think all of you would aware about that. You might have to keep a compression. So she keeps compressing. And after half an hour compression, she's comfortable. She places a bandage and she moves out. Then suddenly you find out after 1 hour, you find the patient is having severe hypotension and falling. So immediately the first thing they think is there is a hematoma happening there. They keep looking at the femoral area. Anything is there? Anything wrong? Maybe there is a hematoma, etc. But what has happened is there has been a mild cardiac rupture and the patient has developed a cardiac tamponade. So these are things. So immediately the most common thing post hematoma removal hypotension will be a hematoma. Post sheath removal will be a hematoma. That is what our mind will think. But we also have to look at the other causes also. So these are things which come to my mind immediately. So you just have to look at all those things and factor in everything and try to do things as fast as possible. Thank you, sir. Thank you.
Thank you for such really good examples, very good examples for our listeners, for people who are any further questions for our speakers, please post them in the chat box. But one of the things that I've seen in clinical practice, especially when both doctors and nurses are busy in stabilizing one critically ill patient, whether it's in the unit or ER or in the ward, the two things happen. One is that this patient takes a lot of attention. It's usually 2-3 doctors, 2-3 nurses trying to stabilize one patient. And other patients are then put at risk because people move away from their patients to help with this particular patient. So that's one scene. Any comments on that? Momita, please. When the nurses are called away from their own patients to help with the patient who's sick, what are the steps that you would suggest our speakers they take so that your own patients who are otherwise stable are not put at risk?
Yes, sir, you are definitely right. When we receive a new admission, so all the staff tend to focus on only the new admission, and they forget about the continue monitoring of the rest of the patient. So mostly all the staff will be gathered around and trying to stabilize the patient, and then stop monitoring the rest of the patient. So when patient is going to deteriorate, then you miss out the early warning signs of patient, then and sudden patient is sudden crash. So patient will not be sudden crash. So patient will be definitely showing early warning sign that patient is about to deteriorate. So if you move out from the patient side and you miss the early warning signs, and then we miss the chance that patient will be suddenly collapse. So there will never be a suddenly collapse. So patient will definitely show early warning signs. So I would like to suggest all the staff nurses who all are watching in this group that you have to always make sure that organized. This has to be done by the team leader. That the team leader in the shift is a very vital important role. That it's her role and responsibility to divide the works and segregate and categorize the responsibilities. That who is going to receive the patient, who will be the circular nurse, and who will help in the assisting. So this all has to be categorized by the team leader. And those who are taking care of sick and critical patients should not move out from the patient side to help the new admission patient. So I think this has to be, and we have to keep in mind and the focus on these points.
Brilliant.
If
Thank
I
you.
may add a point, yeah.
Sure, please.
Yeah, I always feel a very good ICU, a successful ICU, the backbone is the ICU nurse in charge. She is the most important person, the team leader, as she clearly told. And to all my junior doctors who are looking here, you might not have an ICU consultant 24/7 always with you inside the ICU. But when your nursing in charge, ICU nursing in charge, comes to you with a particular issue, and she feels that the patient is not doing well, don't ignore her. Okay. She is there, and she is as good as ICU consultant in picking up things. With experience, they get all this. So please listen to them. And my nurses have been excellent, and they pick up things and tell it to us even before. Sometimes we might miss them, but they're able to pick it up. I think the ICU nurse in charge is an extremely crucial role. And in every hospital, it has to be seen to that ideal persons suited to that are placed in that position. Yeah.
Very well said. No, I agree with you entirely. I think ICU is real teamwork. And that is exactly what we are trying to reflect in our Apollo Knowledge Series program, so that we are discussing these issues together. That is one issue, how you organize the staffing levels for other patients when you get, and Mamta, you're absolutely right. The charge nurse should step in and prioritize the patients depending upon their condition and stability, et cetera, et cetera. Other thing that I have often seen is that people get so busy in stabilizing critically ill patients. And after that, once the patient is stabilized or moved away or gone for procedure or gone to theater, there is big sigh of relief, and then you get back to your work. So what then misses is the adequate documentation. And so many things have happened, so many steps have happened, but they have somehow not been captured in one document or the other. And you then, if 24 hours pass or 36 hours pass, all those events get fuzzy a little bit and the details get lost. Now, if these patients' notes are evaluated by a lawyer or by an external examiner, they are going to say, did you do this? And if you did this, where is the evidence? And without adequate notes, that becomes impossible. So any pearls of advice, pieces of advice as to how that can be managed, either by reflective notes or contemporaneous notes, how do you suggest we try and capture all the events while we are stabilizing a critically ill patient? Dr. Ebenezer, you want to take that one first, and then I'll ask Momita, please.
Yeah, I think This is an area where I have been fighting a lot. And I always felt an Apollo nurse has multiple arms, multiple legs. Okay. And she's been asked to do everything under the sun, from taking care of patients, from documentation, from running the MRD work, etc. So many drills, everything they have a role, and they do a great job about that. But as Dr. Sir was telling, it's very, very important that our documentation is pakka. See, that is the only thing which will save us when we have a problem with litigation. And we have to bring in the system at the sense that it has to be more, the access has to be much more, in the sense maybe systems have to be more. And many times I have seen that nursing stations are always clogged. 2-3 systems are there, and almost all the sisters take timeouts and they come in and they fill the notes. Probably if you can have systems in every cubicle, that's what I've been fighting for, so that they can fill in the notes whenever they have the free time, etc., or anything, they can fill it as early as possible. So these are things which I think we have to do it for them, and if that will definitely lessen their workload. And manpower is an issue which we'll always be facing. At any particular time, we will not be having the correct manpower to address these issues, but maybe software, maybe some other issues like MedMantra, etc., that can be developed much more so that it can be user friendly. And this will in turn see to that much better documentation is in place. And you can have, if possible, if manpower permits, you can have a separate person who can look into all this and see to that the documentation is in place. Yeah.
Thank you.
Yes.
Ms.
Yes,
Momita,
sir.
do you want to add to that? Yes.
Sure, sir. I completely agree with the Dr. Abhineza, sir. Documentation is, vital role in our nursing, section. But documentation should not be duplication. And when you maintain the documentation, it should be short and brief. And every event of patients has to be, captured in the documentation. And it is, always important to maintain documentation. And if it is documentation, I think maybe if electronical if it is converting into not in hard copies and electronically it's converted, and it will be reduce the workload of the nurses. So because when they are working at the patient side, and if they do side by side at the patient side, and it will be more easier and time consuming. They're coming out of the patient side and doing documentation is time consuming. So if they do at the patient side and with like any laptop or tablet, they side by side, for example, administration of medication. So after administering medication, they can just tick on the laptop, then finish it. So it will be easy for the nurses and reduce the workloads of for the nurses.
Thank you. So I think you're absolutely right. Being mindful that can be something that can happen. So being mindful of it, so that people can capture it as soon as possible. But certainly EMR, electronic medical record, will, if you have to tick the boxes and you have to go through certain, you are less likely to miss the information, and free text there allows you to put in more. So certainly those are the things that we at the College of Excellence, not college, at the Center of Excellence in Critical Care are trying very hard to have Apollo-wide, EMR implemented, electronic medical record implemented in critical care units. So please watch the space. We should have that. I wouldn't say soon, but in due course. But this is certainly a priority for us in terms of our work streams. I have a question here, which has come from one of the participants. If a patient comes to critical care with a DKA, what would be the initial line of treatment? So in very short, Dr. Ebenezer, if you could treat DKA.
Okay. For an intensivist, treating DKA could be the most gratifying thing. Okay. And when patient comes in, he is very sick. If you see the acid ABG, that could be severe metabolic acidosis. Sometimes patient will also be very drowsy, and you look at the blood sugars will be very high, and you will be feeling that the patient is extremely critical and ill. But if you're able to diagnose the problem, what's happening, you fix the problem as DKA, you send your serum ketones, urine ketones, etc. You get a diagnosis. And then when you start treating them, fluids is the mainstay of treatment. So when you give them adequate fluids, don't chase the blood sugar. Okay, just giving insulin alone will not solve the problem. So fluids will be the mainstay of treatment. So as you give them a lot of fluids, supplement with insulin, and see to that electrolyte abnormalities like potassium, etc. is corrected appropriately. Within 6 to 8 hours, you'll see the patient is completely turning around, and you look at the follow-up ABG also, the acidosis would have disappeared. Extremely gratifying, provided you pick up correctly and treat appropriately. If you don't pick it up, then it's a very, very disastrous situation. Okay. Yeah.
Excellent, excellent answer. You're absolutely right. I think the sugar can be controlled over a period of time, but fluids remain the mainstay of the treatment. And of course, you follow ABCD approach depending upon the patient's condition, definitely. Okay, thank you for that. Any comments from the participants? Any participant who would like to come in and say something? I can see Ms. Muthuram's there. Some of our leaders are in the participants list. So any pearls of wisdom from any of the participants? If you could raise your hand, please, that will be great. Because then Jude will be able to unmute you. No, looks like everybody is gratified with your talks. I have certainly enjoyed both the talks. I think they bring in not only the nursing and medical approach, which is very systematic approach of ABCDE, but also all the other points of providing a compassionate and empathic care, being communicative to the patients, being respectful to the patient's needs, but also the needs of the relatives. And also the common pitfalls which may be there in our clinical understanding, and just not look at the monitors, but also look at the patients. Excellent talk, excellent talks, both of them, and excellent take-home messages. Gopal Muthuram's got hand up. Please. Ms. Muthuram.
Good evening. Good evening to you.
Good evening.
I appreciate Memota Devi to talk in detail about the levels of care in the critical care. Also, we always think that critical care means the patients are on ventilator. The imagination generally goes with highly dependent patients, but we do have a patient who is coming out of critically ill. All type of patients from admission criteria to discharge criteria kept there in the critical care unit. And we have a good system in our Apollo system, having a pre-med nurse to assess the patients in the ward on the criteria, so that early warning signs are picked up even at the ward level. Who is prone to have a critically ill situation are identified and moved out with the help of critical care consultant. And also, it is a great highlight that many of the things during the resuscitation we use, and we do have a form like during the medical emergency team recorder form, but most of the time after resuscitation of the patients, we try to fill it up when the audit takes place within 24 hours by the in-charge nurse, and identifies always one or two other things like missed out from there, rightly pointed out. And we tried in our Apollo, in our critical care unit, having a system placed in every cubicle. That will help us avoiding the movement from the patient bedside to the counter in view of viewing the facts, reports, and other things. But still we find problem in having the documentations, because most of the time the nurse, doctors, the team handling the patients are with a gloved hand, not able to operate it. I think still we need to find a solution for a method of having a documentations.
Thank you, Ms. Butram. Again, absolutely right. I think one of the reasons for having these discussions during these Apollo Knowledge series is so that we find out where the attention is required on pan-Apollo basis, where we need to work together to find solutions.
Yes.
Not every problem can be solved at once, but being mindful that these are the issues that we need to deal with is part of the solution itself. So it's great to hear those pearls of wisdom. I think we are coming to the end of our 90 minutes time period, which has been really usefully utilized. We had a number of participants today. Really gratifying to see, when the numbers go in triple figures, although they slip down as we reach the end, which is fine. I hope you all enjoyed it. I hope the participants enjoyed the session. I hope the speakers enjoyed the session. And with that, let's now wait for our next session, which you will hear about very soon from Jude.